Good afternoon. My name is Xiao Li, but you can call me Lila.
Hello, my name is Amanda Oliphant.
My name is Mehmet Enesinam.
Good afternoon, everyone. My name is Devesh Malgavi.
Judges, will you please introduce yourself with your name, academic degree, and current position?
Sure. Brian Sick, I'm a physician here at the university, and I'm the Associate Vice President for Academic Health Sciences.
Good afternoon. My name is Chris Myers-Janda. I am a VP at Premier, and academically, I have a master's in healthcare administration and a bachelor's in physiology.
Hi everyone, my name is Carolina de la Rosa Mateo. I have a master's in public health, and I'm the director of operations at a nonprofit called ASER.
Good afternoon. My name is Eric Maurer. I'm the Innovation and Strategy Officer at Kook. I've got a master's degree in health administration as well as health informatics, and my bachelor's is in psychology.
Hi, sorry. My name is Sophia Ali. I am the medical director at Southside Community Health Services. I have an MD and an MPH.
My name is Paul Gehring. I'm a psychiatrist and a post-career physician executive.
Thank you. Let us know when you're ready and we'll start the timer.
Sorry, quick question. Where will the cue card? Oh, perfect. Thank you so much. Okay, we're ready. Good afternoon, everyone. My name is Amanda, and these are my colleagues, Lilac, Mehmet, and Devesh. We together represent the Technology Empowered Alliance Management. We are honored to have the opportunity to work with you to implement shared visits at the Community University Healthcare Center here in Minneapolis, Cook. And we're excited to share with you our plan for ensuring that the program is a success. This is the outline of our presentation. We'll give some background information before detailing our plan for shared visits at Cook. Then we'll talk about the long-term success of the program, how we'll measure that and ensure how it grows in the future. After our conclusion, we'll be happy to answer any questions you have.
So first thing, we start looking at the Cook's population so we can tailor our solution accordingly. First, we identify that the population, 90% of it are uninsured or rely on government's insurance. Then we have 97% that self-identify as very poor or very low income or low income. And generally the population is young age, and they have conditions that are complex in nature like diabetes and cardiovascular diseases. So it seems to be fitting to the shared care model. We also look into the ethnicities, and we have high representation at Cook of diversity, especially when compared to the 2017-2021 census from the Minneapolis. And this identifies two potential barriers. One is language barrier that we need to address maybe, and then another is the ethical perspective towards the shared clinic concept.
This shared visit model has shown significant potential in various settings, including but not limited to diabetes, obesity, chronic heart conditions, chronic kidney condition, and asthma, which specifically aligns with Cook's demographic. Additionally, shared visit has shown benefits in improving the patient-provider relationship, increase patient empowerment, cost efficiency, and enhance equality of care. Now, let's take a look at few of the case studies from Cook's shared visit program. All of these cases have complex medical histories and diverse healthcare needs. While it was thought that shared visit would be an appropriate solution for these patients, implementation did highlight some of the important challenges in shared visit program. Upon analyzing these cases and prior research, it was evident that challenges could be traced back to three important stakeholders: patients, providers, and organization. Patient expressed negative perception to this shared visit due to length of appointment, time of the work, and transportation issues. Additionally, complicated and intimidating nature of this shared visit decreased patient participation in this. Providers face challenges such as lack of coordination, trust, mutual respect. Additionally, billing structures and reimbursement policies made it hard for providers. At the organization level, the challenges were inclusion criteria for patients, then maintaining financial sustainability, and managing both the traditional model as well as shared visit model.
Our plan is based on the concept of value-based care, which include first, care delivery. It is a team-based care program. We will appoint registered nurse care coordinators who serve as the main point of contact between patients and physicians to facilitate the program. Second, benchmarking. We will implement a national value-based benchmark to regularly evaluate our program. Third, payments. Since the majority of our patients is Medicare recipients, so we will apply the pay-for-performance model to improve the Medicaid reimbursement. Also, we will also implement an innovative bundle payment protocol to incentivize physicians to improve their quality while reduce their costs. Last but not least, informatics. We will invest in technology upgrades, including AI assistant pre-screen, coordination, outcome check, and so on.
In order to implement our plan, we propose that part of Cook dedicates 1 day per week to shared visits. Our program centers around forming a strong care team for each patient. And during their shared visits, the patients will see each provider in their care team one after the other while staying in the same room. This idea is modeled after shared visits that already work in clinics such as the VA hospital in Pittsburgh and the Huntington Disease Clinic in Houston. At the same time, we will be implementing technology to increase efficiency and gather data to improve patient outcomes. One of the keys to success in shared visits is a strong, cohesive, multidisciplinary care team. This team will look different from patient to patient depending on their personal needs and their medical and social needs, but each team will have a few key players that will be specially trained to excel in their roles. These include an RN care coordinator, a community health worker, a primary care provider, and a social worker. The RN care coordinator plays a key role right from the start in helping to facilitate patient participation and success in the program. They start out by helping to identify patients that would be suited to the program based on complex medical needs or social needs in addition to medical needs. Once these patients have been identified, during one of their routine visits to the clinic, the RN care coordinator will introduce the concept of shared visits to them using an introductory video. Once the patient agrees to participate in the shared program, the RN care coordinator will act as a consistent point of communication between the patient and their care team. This is really designed to help the patients feel less overwhelmed by participating in shared visits and seeing a lot of providers in such close proximity to each other. The community health care worker plays a really important role in ensuring that any suggestions, interventions that the care team decides upon are realistic within the cultural and social context of the patient's background. Of note, we desire to use employees that Cook already has to fill these roles and train them, and then we can hire more as needed and as budget allows.
Another important aspect of our solution is transportation. Our family-centered shared visit model will reduce the number of times patient needs to come to clinic. Further, we have identified Metro's transit assistance program, which offers reduced cost transportation to those in needs. As our program expands, we are trying to implement shared visit model in Cook's current infrastructure, such as telehealth and mobile clinics.
As for the technology, first thing that comes to our mind is data. We use data to extract information which we can then derive actionable knowledge from, and we can apply this in our clinic to improve human health, right? And this is the textbook definition of informatics. So how we can get that done? We need a data coordinator, data personnel to oversee all the data activities. This person would also communicate this data with the rest of the team. We envision potentially to use the OCHIN, who is in partner with Cook, and they're working with Epic. So we can get people from them that will help. We can hire them as well ourselves. The idea is having an AI to, again, develop this pre-screening process to help with the process, to improve our accuracy, identifying these patients, and to better care them. And then the user interface person would actually get this information, quality improvement throughout the project, and then this decision support, and put it into a platform that can be presented to the physicians or providers in all that care. And we initially we hope to have this integrated to the HR system with Epic, but due to the policy difficulties, we might be able to do it as a tertiary, as an initial, and we can discuss the details.
Our shared visit program works really well for individuals, but it can also be applied to families. As an example of how that works, we're going to discuss the Morales family. They immigrated to the US from Mexico 10 months ago. They experience food insecurity, and they have several barriers to receiving regular health care, including transportation and language. In addition, 3 members of the family, Elena, Adriana, and Ignacio, have specific medical needs. Of note, Ignacio is based on patient D from the case. What would happen is an RN care coordinator would identify the Morales family as good candidates for the shared visit program. When Elena comes to the clinic for one of her routine visits, the RN care coordinator will talk to her about the concept of shared visits, share the video with her, and ask her to participate. Once Elena agrees, a team will be formed for the Morales family. The RN care coordinator will help schedule appointments for every member of the team, including the community health worker fluent in Spanish, a family medicine provider, a dietitian, a pharmacist, and a social worker. The social worker will help arrange transportation for the Morales family to the clinic on the day of their appointment if needed. They will arrive to the clinic at 8:30 for check-in, and beginning at 9 o'clock, they will have an hour-and-a-half-long visit with our family medicine provider, during which each of the 3 family members will be discussed and examined. Following that, they will have half-hour visits with their dietitian, their pharmacist, their social worker, and their community health worker before checking out at 12:30. That afternoon, the team for the Morales family will meet together to consolidate a care plan that includes medications, diet, local food bank resources, and regular counseling visits for Elena, who expressed to several of the members of her care team that she was having anxiety about adjusting to life in the US. The RN care coordinator will then communicate this plan to the Morales family and take any questions that they have for the care team. This is how it might look from a provider's perspective. In this case, we'll be following an MD who specializes in family medicine. In the morning, she spends 3 hours seeing patients, 1 patient per hour, or 2 families for 1.5 hours each. After a lunch break, she'll see 2 more patients before spending the rest of the afternoon in team meetings.
Patient satisfaction and the physician satisfaction survey will be conducted pre, during, post-treatment in order to measure our success. Based on the survey results, we will be able to continuously improve our program. We also will implement 4 metrics to measure our success. First, quality. Using advanced event rate, mortality rate, patient satisfaction, to compare benchmark of National Association of Worksite Health Centers. Second, scope. As we mentioned before, our clinic scope will include the chronic disease, mental health, telemedicine, and so on. Third, cost is mainly focused on patient cost and the coordination cost. And last, time, which will measured by the how efficiency is improved from the physician perspective and how much time saved from the patient perspective. To maintain our program's financial sustainability, we have identified several ways. The first, there are multiple funding resources that we can tap in. Second, we should maximize the revenue through the maximize the reimbursement from payers and extend the revenue channels. Third, cost control. We should do the cost control by optimizing the staffing level and operation efficiency and developing a culture of cost control. Next, we should build a long-term partnership with the labor service, community organization, and transportation service and home and abroad specialist. We also will implement a robotic process automation system to facilitate coding and billing process. As we mentioned before, we will invest the technology upgrade to improve the efficiency and improve the care accuracy. Definitely, we will always measure our outcome to identify the issue timely.
As for the acceptance criteria of the project, we want to actually focus on the safety. So we want to look into the adverse events. We want to look into readmissions. We want to look into the emergency admissions for these patients. We want to then move into the efficacy in terms of like the 3 groups that we have identified: the organization efficacy in terms of budget and their cost resources, and then patient time, physician time. We want to value these things, and we want to compare it to the existing platform that we have, the workflow. And then finally, we have the quality. The quality will be done with the interviews and the questionnaires towards the end of the program, and we will be routinely checking it, trying to see how we're doing. Based on the acceptance, with the success, then we want to expand this program to a separate department, potentially at Cook, and then have it a full week, full-time shared clinic, and then we would be, by then, enhancing our development with the AI, and then we will move on from there.
Let's recap what we learned today. The current fragmented model of healthcare delivery often leads to inefficiencies and reduced quality of care. To address this, we are proposing value-based care model strategy, which is patient-centered and efficient and would benefit all stakeholders: patient, providers, and organization. In conclusion, our solution of value-based care model strategy would help benefit or would help better the current interdisciplinary healthcare shared visits. These are our references, and thank you. We are happy to answer any questions you may have.